Thank you for having me talk today. As Sandy mentioned, I'll be talking about CF cultures. So my objectives for today are to describe what a culture is and why it's done, to review what culture results mean, to discuss, oh, I realized I didn't turn my camera on. Sorry, I'm going to do that really quick. Or not. Never mind. What's that? Well, once I start my slides, I can't. But you don't need to see me. My slides are more important. I'll turn it on for questions. So review what a culture result means, discuss the sensitivities and susceptibilities, and then talk about what you can do to prevent infections. So what is a culture and why are cultures done? So as Dr. McNamara mentioned, the gene that causes cystic fibrosis disrupts the flow of salt and therefore water in and out of the cells in the lungs and multiple other organs. And this salt imbalance results in thick, sticky mucus that allows bacteria to thrive and multiply and puts people with CF at risk of having frequent respiratory infections. Those infections can lead to increased cough and increased mucus production, and a throat culture or a sputum culture help us to detect and identify the bacteria that are causing those infections so that we can use the most effective antibiotics necessary to target the infection. This image is a cycle of infection and inflammation and damage that can occur if we don't treat lung infections. So if we look at the very top of the image, because of the changes in the CFTR protein, you get thick mucus that tends to want to get stuck in the lungs and causes plugging in the airways. And this impairs the cilia from moving the mucus out of the lungs in a normal way. That creates an environment where bacteria or other microorganisms want to grow and replicate. That attracts white blood cells, predominantly neutrophils, that then attack that bacteria. But as those neutrophils break down, they release chemicals that then result in more inflammation, and you can get increased exacerbations, worsened clinical symptoms. And as that cycle continues, you get loss of ciliary function, and eventually you can start to get destruction or changes in the airway wall, which is called bronchiectasis. As bronchiectasis forms, you get more mucus retention, and then this cycle continues to progress. So part of why we treat positive cultures is to break this cycle. So we treat the microorganisms, which then impairs the white blood cells from coming in. You don't get that increased inflammation from the white blood cells breaking down, and hopefully you prevent the destruction of the airway wall and stave off the development of bronchiectasis and the progression of lung disease. As Dr. McNamara mentioned, the CFTR modulators that have come on the market, hopefully they restore normal function to the protein, which results in normal thin mucus, so helps to break the cycle even sooner. And then we don't even have to begin this whole process. But until there is a medication for all children, all patients rather, with cystic fibrosis, we have to continue to surveillance for bacteria. So we do the cultures, and oftentimes families don't quite understand what the results mean. And I do think we take that for granted. So back to the basics. So before we can get to the results, you have to know what happens. So the sample is collected and sent to the laboratory. It's placed on a special plate that enables the growth of bacteria. And it takes about 48 hours, sometimes longer, for the cultures to grow. And then the bacteria that grow are analyzed either under a microscope or using a variety of special tests to identify what bacteria is growing. And then once the bacteria is identified, it is plated on different mediums to determine what is the best antibiotic to treat, which can take another couple days to result. And not all bacteria that grow in cultures are treated, and you've probably experienced this with your child or with yourself. So this graph is a graph of the prevalence of respiratory organisms by age. And what you see is that people of all ages with cystic fibrosis grow different bacteria. So most younger children tend to grow Staph aureus, and then as people get, which is the green line, as people get older, they start to grow more Pseudomonas. You'll note on this graph, the bottom yellow line is Burkholderia cepacia, which I'll talk about a little bit more in a little bit. And then this red line is MRSA. So which organisms are automatically treated? So some organisms have been shown to be more dangerous for people with cystic fibrosis and may lead to a faster decline in lung function. Those include Pseudomonas, MRSA or methicillin-resistant Staphylococcus aureus, Burkholderia cepacia complex, Aspergillus, particularly allergic bronchopulmonary aspergillosis, or ABPA for short, and Nontuberculosis mycobacterium. So patients will grow a variety of bacteria, but these are the ones that we treat most aggressively when they grow in cultures. Pseudomonas is widely found in the environment, and it thrives in moist environments. So humidifiers, catheters, kitchens, bathroom, pools, hot tubs, sinks. It's an opportunist, so it grows in people who have cystic fibrosis or have weakened immune systems from a variety of other causes. It is the most common bacteria found in adults with CF and among the most common in all people with CF. About 50% of adult patients with CF will have Pseudomonas. That being said, with the onset of modulator therapy, cases of Pseudomonas have been decreasing. Historically, once Pseudomonas has been established in the airways, it's been difficult to eliminate, but that too has changed with the onset of modulator therapy. We still treat positive cultures for Pseudomonas aggressively so that we can delay the development of complications. MRSA, or methicillin-resistant Staphylococcus aureus, is a type of Staphylococcus that is resistant to oxacillin or methicillin. It causes skin infections in the general population and can cause pneumonia in the general population, but in the CF population tends to cause infections mostly in the lungs or sinuses. It can be resistant to several common antibiotics, not just oxacillin, but typically there are some antibiotics that can be used to treat it. It has been shown to worsen lung disease and impact survival in people with CF. We have a lot to learn about MRSA, so in Pseudomonas we'll often treat a positive culture aggressively and we're able to eradicate Pseudomonas. And while we attempt to do this with MRSA, it's not always as easily eradicated as MRSA can be. And it is difficult to eradicate, as I mentioned, once grown. Burkholderia, thankfully in our patient population and on that graph that I showed a few slides ago, is not a very common bacteria, but it is an important bacteria to treat if it grows in a culture. So like Pseudomonas, it grows in damp and wet places. It is often resistant to many antibiotics. Burkholderia cepacia complex is about 20 different species of bacteria. Some have more serious implications than others. And much of what we do in terms of our infection prevention control practices in clinic or at cystic fibrosis events is related to preventing the spread of Burkholderia cepacia. Like Pseudomonas, it's also opportunistic and has been shown to cause a rapid decline in lung function and death. Aspergillus is a fungus that lives in the airways of children and adults with CF. And when people develop an allergic reaction to Aspergillus, it's called allergic bronchopulmonary aspergillosis. It's a common fungus that lives indoors and outdoors. We all breathe in Aspergillus spores every day without getting sick. People with CF, though, are at higher risk of developing health problems because of Aspergillus. About 2 to 19% of people with CF, depending on the source that you look at, will develop ABPA. which causes inflammation in the lungs and then can cause further scarring, fibrosis, and decline in lung function. It's more common in older individuals. And risk factors for the development of ABPA are declining lung function, a history of asthma, allergies, and sputum that has grown Pseudomonas. And with ABPA, often a patient's symptoms will get worse without any other clear explanation. We'll try to treat them with antibiotics and they won't improve, and then ABPA will be identified. Many people with CF will have a sputum or throat culture that grows Aspergillus. We don't automatically treat the Aspergillus in cultures because it doesn't mean you have ABPA. The body's response to the allergy of that Aspergillus and the symptoms are what determine if you have ABPA, and other testing is done to make that diagnosis. Nontuberculosis mycobacterium, also known as NTM, live in the soil, swamps, water sources. Again, in Minnesota, thankfully, we do not see a lot of NTM, but we have had patients who have had it. NTM survives many disinfectants and really severe environmental conditions, so it can be hard to eradicate in the environment. There are more than 100 types of NTM, but the two most common that we see in people with CF are Mycobacterium abscessus or Mycobacterium avium complex, also known as MAC. And this group of bacteria are kind of cousins to tuberculosis. They used to be called atypical mycobacteria, but they cause a distinct disease compared to tuberculosis. About 13% of people with CF have had a positive culture for NTM. As I mentioned, here at our center, we've had a very low rate of NTM. It enters the lungs through exposure in the environment, and because the organisms live in so many different environments, it's difficult to avoid. In the U.S., about 75% of NTM is MAC and 25% are abscessus. So why don't we treat every culture? So some of the bacteria that grow in CF cultures are not associated with a decline in lung function. We want to preserve antibiotics and to prevent the development of antibiotic resistance. We want to be stewards of antibiotic use. But we do use those results even for those bacteria that we don't automatically treat to treat pulmonary exacerbations of CF. So if our patients have increased cough or sputum production, if they have worsening shortness of breath, fever, loss of appetite, or perhaps a decline in lung function, we will use past cultures for current treatment, and it helps guide our choices. When you get your culture results, sometimes it will say there's normal flora or usual respiratory flora. That's the bacteria that are always present on or in a person and usually do not cause any disease. And with the advent of modulator therapy, more and more of our cultures are coming back with usual respiratory flora. Sensitivities and susceptibilities. A sensitivity test checks to see which antibiotic works best to treat the bacteria. If you are logged into our patient portal through our clinic, particularly if you're looking at it on the app on your phone, this is what the results might look like. And it can be a little bit overwhelming to look at these images because of course, when you see red, you think it means bad things. But in reality, most of the information on this slide is good information. So in the upper left corner, it shows 3+ usual upper respiratory flora. And then it shows that there's 1+ Staph aureus. There's a lot of information in the left-hand column that's important to me as a provider, but really as a parent doesn't mean anything. And then if you move to the right-hand column, you'll see that there's a list of antibiotics on the left side, and then it tells us which are susceptible and which are resistant. So as I mentioned, if your child were to have a pulmonary exacerbation, we would look at this and choose the appropriate antibiotic to treat the infection. I would note that sometimes we have patients who will go into urgent care with a earache, and they'll see a provider who's not familiar with cystic fibrosis, and they might put them on amoxicillin, which is a typical antibiotic used to treat an ear infection. But if you were this patient and had an ear infection and the provider put you on amoxicillin, you can see here penicillin, which is the same class, is resistant. So having access to the portal and being able to provide this information if you're seeing someone other than our providers can be helpful to make sure that if your child's being prescribed antibiotics, it's an appropriately chosen antibiotic. So how can you prevent infections? As I was going through the slides about the different bacteria that we treat, most of those bacteria are ubiquitous in the environment, and so we can't live in a bubble. So there are some things that you can do, however, to decrease your risk of infection. When you're around others, particularly at CF events, where they may have organisms that may be harmful, make sure to keep a safe 6-foot distance apart, wash your hands, cover your cough, clean and disinfect your nebulizer. So nebulizers are wet, and it's important to care for them properly. Our respiratory therapists should be reviewing with you that process on a regular basis. Don't share personal items, particularly between people who have CF. Avoid frequent contact with dirt. This is particularly important for NTM. Let your school or workplace know that you have CF. If there's other children in the school with CF, they can implement different practices. Get vaccinated, and of course, if you have questions, always know that you can talk to your CF care team. And with that, I'm happy to take any questions.
So I actually have a question, Brooke, that some of the families might be interested in. Are we seeing a change in the bacteria in the lungs since most of our patients have access to the modulators now, like Trikafta?
Yeah, so we have definitely seen a decline in Pseudomonas cultures, not just at our center, but nationally. I think we've also seen a decline in MRSA. We have some patients who have grown things like Stenotrophomonas, which I didn't mention today, that they have cleared that and aren't growing that either. So the modulators do seem to be impacting that microbiome and that sort of cycle that I showed at the beginning in terms of chronic infections.
And I actually have a question, too, for you, Brooke. A lot of our families ask about MRSA. Is that contagious? Because they hear about it in the, the groups of classrooms, et cetera. Can you comment on that?
So MRSA is really everywhere in the environment. It used to be thought that it was something that was mostly in hospital settings, but there's as much community MRSA as there is in hospitals anymore. And so kind of like the other organisms, you can't prevent being exposed to it, but the infection prevention practices I mentioned at the end can help decrease your risk of acquiring it.